Gardner syndrome is a dominantly inherited intestinal adenomatous polyposis with extracolonic manifestations. It is also known as FAP or familial adenomatous polyposis. Greater than 70% of patients with this syndrome will also develop extra intestinal manifestations such as multiple osteomas, dental abnormalities, and a variety of other lesions located throughout the body. This syndrome was first described in 1950 in a report of one family, all descendants of one couple. There's no history of cancer on the father's side of the family. The mother was the proband, and she died of colon cancer. 9 of her 45 descendants in 2 separate generations also died of bowel cancer. Soon after this report, other pathologies such as osteomas of the skull, fibromas, lipomas, and sebaceous cysts were discovered in association with this syndrome. Later, desmoid tumors and dental abnormalities were also found to be associated with Gardner syndrome as well. The incidence of Gardner syndrome is about 1 in 14,000. The intestinal polyps are usually detected in the latter half of the second decade of life and usually become cancerous about 15 years after the diagnosis is made. The risk of developing an intestinal malignancy is almost 100%, with 50% developing colon cancer by the age of 35. Other malignancies may also include carcinomas of the adrenal glands, thyroid, and bladder. Turcos syndrome also may occur in patients who also have neuroepithelial tumors. The ocular manifestations of Gardner syndrome were first described in 1980 by Blair and Trempe. They examined 9 members of a family who had Gardner syndrome. 3 of these members, a mother and 2 daughters, had hypertrophy of the pigment epithelium. They all had colon polyps. One patient had 5 lesions in the right eye and 12 in the left eye. The lesions were oval or round and about 2 disc diameters in size. The second patient had 4 lesions in one eye and 1 in the fellow eye. The mother of these 2 patients had 4 lesions in the right and 6 in the left. In all patients, the lesions were randomly scattered throughout the fundus, and none were of the category that we would call grouped pigmentation. Now here's an example of bear track or grouped nevi, as I mentioned in the last slide. This is a benign condition. Shields et al. Studied 132 patients with the diagnosis of congenital hypertrophy of the pigment epithelium, either solitary or grouped. One patient had intestinal polyposis, but no cancer. Among the 2,000 blood relatives of these patients, only 20 had polyposis or colonic cancer. This 1% incidence was far less than that expected if these lesions were associated with familial adenomatous polyposis or Gardner syndrome. Here, however, is a typical lesion of Gardner syndrome. It is dark, like RPE hyperplasia, but it has an oval shape or almost a torpedo shape, and this is typical of Gardner syndrome. So let's go into more depth on the ocular findings in Gardner syndrome. Some families with Gardner syndrome may not have any retinal changes at all. However, if there are 3 or more chirpy lesions, then there's a high correlation with intestinal polyposis. Therefore, in families with a history of familial polyposis, a proper retinal examination and the recognition of the typical chirpy lesions is necessary because that may identify the patients who are at high risk for getting colonic cancer. However, the lack of ocular lesions does not mean the patient will not develop intestinal polyposis. Clinically, there are varying sizes and shape and pigmentation, but most of the lesions will have that ovoid or fishtail appearance. Here is an example of a patient with multiple chirpy lesions, and as you can see, they can have the typical ovoid shape. Some are larger, some are smaller, some are pigmented, and some are not so pigmented. Here is a 13-year-old girl who's noted to have spots in both eyes about 2 years previously. Her vision is 20/20 in the right eye and 20/25 in the left eye. The blue arrow on the temporal aspect shows a very typical Gardner Syndrome chirpy, and on the nasal aspect there are two smaller areas pointed out by the blue arrows again, and these are rather small. This is the same patient, but a much larger photograph of the nasal retina, and again, you can see the small pigmentary changes of chirpy. This is a photograph of the left eye of the same patient, and you can see the typical ovoid chirpy lesion nasal to the nerve. Infratemporally, in that same patient, you can see two other areas of pigmentation in the infratemporal mid-periphery. And not to be redundant, but here's a 32-year-old who does have familial polyposis, and you can see the chirpy lesion in the temporal macula. There were some other faint chirpy lesions nasally, but these did not photograph very well. We'll end our discussion on Gardner syndrome with several histologic slides. These came from an article in the AJO 1990 by Trabulsi and Murphy. They studied a patient with Gardner syndrome. Most of the lesions were histologically similar to other chirpy lesions. The pigment epithelial cells were enlarged and filled with round pigment granules. The overlying photoreceptors were partially atrophic. They also found several other types of lesions. One looked like a hamartomatous change extending from the pigmented epithelium through the inner retina, and the other change were areas of cellular hypertrophy. Here is a more magnified histologic slide showing the large, round pigment granules and a thickened basement membrane. This is a scanning electron microscope area of normal-looking periphery in Gardner syndrome. There are single and clusters of enlarged pigment epithelial cells. And again, this is a normal-looking retina, and this comes again from the same article in the AJO in 1990. And here is the slide of that hamartomatous change that extended from the pigment epithelium through the retina into the pre-retinal space. So in summary, Gardner syndrome is a dominantly inherited familial adenomatous polyposis. There's a very high incidence of colon cancer. Many times people will develop this in their 20s and 30s. And multiple ovoid chirpy lesions signify a higher risk for that patient for developing the colon cancer.